The pandemic happened this year. How did that alter the course of MetaMe and your focus on data?
So when the pandemic first struck, the first thing we saw was that data was going to be really critical to winning the battle against the pandemic. And we just didn't have data. It was like, how many cases are there in Wuhan? How many cases are there in China? How many cases are there in Europe? Can you believe the data that we're getting from China? Can we believe the data that we're getting from the CDC?
Sorry, but just interestingly, the individual level, we're all looking at this data. I remember, the stress at the beginning of we're looking at Johns Hopkins website when it started to be the kind of the central point. And my wife is a scientist, so for us it might be a little bit more natural, but I know everyone out there who was taking a look almost every day. And so your story we're really interested in terms of your lens, which is already so trained on data. So I'm all ears.
No, absolutely. And you're right. We were looking at Johns Hopkins and, King's and looking at data because it was all so new and we had a data crisis. We just didn't have the information to know what to do. And we still do in many senses, right? We've gotten a lot more information. We've got 6 months of data now, right? So we're in a better position than we were at the beginning of the year. But for us, we saw there was a data crisis. So initially, we tried to approach the pandemic by proposing that our protocol could help with the data crisis. Because basically, one of the things that is really key about our protocol is that it enables individuals, or we call it entities, and that could be an individual or an organization effectively, to share data into a commons, so into an open network where that data can be made accessible to different researchers, multiple parties, whether those are pharmaceutical companies, academic institutions, public health bodies, etc. So we see this as a critical resource to have this data commons of data, ideally globally, a global data commons that we can collectively interrogate. But the important thing is that privacy has to be preserved for the individual in that commons, and property rights need to be preserved in that commons. This is a very big problem for all these data networks and data commons out there. But our protocol, because of the way we manage data and because we can isolate data down to these data sets and put these blockchain smart contract rules around it, we had a solution for that. So that's what we were thinking would be the initial value that we could bring. But it was very abstract. We spoke to, government agencies, defense departments, VCs, etc., hospital systems, and everyone was like, that's great, but we've got a burning fire right now. There's a pandemic we're dealing with right now. That sounds nice in 6 to 12 months' time, the possibilities of the future. So we weren't getting any traction on that idea of using our platform for data. And then we started to say, okay, well, maybe we can do something more app-based that's a little bit more specific. And actually, to be honest with you, that actually came because we came across a technology. We weren't even thinking about building an app, but we came across a technology that enabled us to be able to derive oxygen saturation levels just from looking into a smartphone camera. And we realized, because we've been following all the data at this point, oxygen saturation is a key indicator of risk. And COVID has this particular anomalies around low oxygen saturation levels within people who seem to be behaving normally.
You found technology that allows oxygen saturation to be measured by looking at a smartphone camera.
Yes, I know, it's really crazy because basically what it does, it looks around the eye socket area and it's great. It doesn't even analyze the irises or anything like that, but it just looks around the eye socket area. And because video is shot at more than 20 frames per second, it can basically take each of those frames and analyze the data around those frames, particularly the metadata. And so it's looking for contractions and extractions around the eye socket area and for changes in coloration which come from oxygen saturation level. And it does this so rapidly, like the new iPhones are like 120 frames per second. So there's like 120 of these photos that it's analyzing every second, and then basically is able to reverse engineer them against an algorithm, which will then detect your respiration rate, heart rate variability, oxygen saturation.
My God, they were not doing this in 1919 or 1920. That's for sure.
No, exactly, right. And this is the thing, tech can help us fight this pandemic. So we came across this tech and then it became clear to us, okay, what we need to do is build a smart diagnostic tool or monitoring tool that is underpinned by our technology in terms of privacy, preservation, and data enablement. And then this is something that we can introduce, that we can give to people to actually help people understand their risk of COVID infection. So we took this scanning technology and then combined that with the best symptoms monitoring checker out there. So there's a COVID-19 study by the Massachusetts General Hospital, King's College Hospital out of London, and a company called Zoe. It's called the Zoe study, and it's open sourced, and it's already got over 4.3 million people who are using this on a regular basis. So we thought this is a great data set to lean into. And it was, for example, the first data set to expose that loss of taste and loss of smell gave an 80% accurate indicator as to whether someone might have COVID-19. So it was really delivering on the promise that the data will show us more about the pandemic. You know, that didn't come from any previous academic materials. It just came from the COVID-19 study where you had 4 million people doing this test, and you could see that loss of taste is actually resulting in people who have shown loss of taste and smell 80% of the time are COVID positive. So we combined that with symptoms monitoring, vitals monitoring, lab test validation and verification, like the passport things they call, and contact tracing. These are the 4 things that you really need to have to understand someone's level of risk. But the problems with symptoms monitoring on its own is symptoms just tell you about how people feel. They're not telling you about how they are. And of course, as we know with COVID, one of the big problems is that we have pre-symptomatic and asymptomatic people. So just asking people symptoms isn't going to cut it, which is what a lot of the survey apps are all doing. So the next thing is vital scanning. So vital scanning gives you a way to figure out how people actually are versus simply how they feel. And in terms of vitals for COVID specifically, the critical ones are temperature, oxygen saturation, respiration rate, and heart rate variability. Well, respiration rate goes hand in hand with oxygen saturation. Oxygen saturation comes down, respiration rate goes up to compensate. So these are medical grade. Heart rate variability is seen more as a lifestyle type reading than a medical reading. It's not really used by doctors. However, again, in some of the studies, we're seeing that particularly with asymptomatic and pre-symptomatic people are likely to be fluctuations in their heart rate variability, because even though they're not showing symptoms, if they're carrying the virus, the body's already started to respond to it and it's already started to fight it, which can play out in terms of HRV changes. So between heart rate variability and oxygen saturation, you start to have additional indicators for particularly, and this is the critical point, particularly in asymptomatic people. Also within symptomatic people, but particularly have a means of actually addressing people who are asymptomatic, who you're not going to learn from symptoms monitoring whether they are exposed or not. So this is a powerful second component. The third component then being lab test results. And again, so testing is a complicated space. You've got PCR, antigen, antibody. We base all of the decisions that are in our protocol off of PCR tests, which are pretty much the gold standard and the more reliable one. But we have a way to capture antigen or antibody test data as well to include that. So you have those 3 things. So you've got symptoms monitoring, vitals, test data. And the important thing with test data is you just want a way to validate the test results and verify that the tests are as they are. But you also do want to capture some data about what kind of tests have been taken and the nature of those tests. And then the last piece is then contact tracing.
Yeah, the big one, and right? This is the area that I can tell you in the United States, and I happen to live in Cincinnati, Ohio. Rashad and most of our staff is in Maryland. It's interesting to compare notes and how this type of thing, specifically how contact tracing has varied from where I am to where they are to where some of our clients are. So yeah, that all ears again. Go ahead.
Yeah, no, contact tracing is a really critical one, and it's critical for 3 reasons to me. The first thing is it started to get all the attention in the privacy debate, right? Because this is what you see. So when you look at the symptoms monitoring, all the symptoms monitoring apps out there were basically surveys, like the Zoe study, which is the best of them, in my opinion. But they're all surveys where people could answer questions, how they felt, answer yes or no, and that was essentially it. So the danger to people about that information being in the wrong hands was relatively low for two reasons. One, very few of them asked you to actually register any information about yourself anyway, which is good, and that is good from a security perspective. But the second thing about those symptoms monitoring apps was that you could answer how you wanted effectively. So you weren't obliged to any truth. Contact tracing, on the other hand, was based on location data. And it was based on location data that was either from GPS or Bluetooth. That was pretty reliable in terms of telling where you actually were. So on one hand, there was the fear of having this thing follow you around and know where you are, and people's location data is a sensitive thing generally in the privacy space. But you also had this now related to COVID as well. And this is a really important point that is lost on a lot of people as to why contact tracing became so controversial. Contact tracing became controversial because you were dealing with objective data around where people actually were, and it was related to people, it's related to people personally. Whereas symptoms monitoring was subjective data. So once you had objective data that was widely available, suddenly the privacy risks become really clear. So, and this was what we understood with symptoms versus vitals, because symptoms are subjective data, whereas your vital scan is objective. So it's telling where you actually are. So the issue from a surveillance perspective and from a privacy perspective is when you bring objective data that cannot be disputed effectively, and especially if you can attest it, right, and you can bring verifiability around it. So lab results, have you taken a COVID test, yes or no? What was the result of it? You know, if you're showing a temperature of 101 or your oxygen saturation has fallen, this is indisputable stuff, right? And if you have that, then the privacy threat becomes a lot more serious. So by bringing all of that together, when it came to contact tracing, we understood that contact tracing was great because it helped us understand the problems with the pandemic. The thing that I do want to stress about contact tracing that is important, though, is that, you know, the world is, in America, we're in a bit of a pickle right now around the rate of infection, the prevalence of the disease in society, right? To the extent that traditional contact tracing is challenged. So, you know, we have analog contact tracing and digital contact tracing. Analog contact tracing is where someone picks up a phone. If I've been diagnosed, for example, then a contact tracer person would ask me, who have I spoken to in the last 2 weeks? Where have I been over the last 2 weeks? I will list all that information, and then someone will pick up a phone and call all those people that I've been in contact with over those previous 2 weeks. That works, and it's the stand that the health industry has been doing for the last 50 plus years and has had huge success, and it's been a tried and proven method. The problem is that with COVID, the pace at which the disease is moving in the community is so fast. So contact tracing, particularly manual contact tracing, analog contact tracing, only really works if you've got a low enough case rate and prevalence rate that you've got enough contact tracers who can stay on top of it. But when you get to the point where you've got massive exposure like we have at the moment, it breaks down. Contact tracing cannot work. Analog contact tracing can't work. So you definitely need to have a form of digital contact tracing, which is basically now, rather than having a person sit down and interview each person who's COVID positive, where they've been, who they've been in contact with, you're using their phone to actually track where they've been and see who they've been in contact with, or at least to notify people they've been in contact with. I think the advantage of that is that you can move at the disease speed. And I think here's another one that I think is really critical. COVID is as deadly, if not more deadly, than malaria, right? And this is one of the last sort of global scale pandemics that we've had. I mean, Ebola kind of, but not really. We managed to thwart Ebola before it became like a real major global problem. AIDS has really been the last major kind of global pandemic, deadly pandemic that we've had that has been pervasive across the world. COVID-19 is as deadly as AIDS, and I would say potentially more deadly because it kills you more quickly than AIDS does. And that's a really important point. It kills you more quickly and it spreads at the pace of the flu. So you've got a disease that's at least as deadly as HIV, as AIDS, but that moves at the pace of influenza.
How do you keep up with that if you're only doing manual contact tracing?
You can't. You can't, unless you keep your case rate so low. If you can keep the case rate down and you keep the social distancing and mask wearing and hand washing and all of those things in place, then possibly yes. You know, because if you're dealing with tens and hundreds of people of infections, then you can contact trace manually. But when you're dealing with thousands and millions, it's just not feasible. So you need a form of digital contact tracing. And this is, I think, the rub where we kind of at butt heads as a society here at the moment.
Perfect. So, with the history that you've just told of contact tracing, we went through a little bit why, over the last 50 years, manual contact tracing has worked pretty well with lower numbers. But now, in certain circumstances, certain countries, and it maybe even certain more specific geographic regions, that's just not going to work anymore. Let's say it this way. What have you done and what has MetaMe done to be unique in the offer of digital contact tracing?
Yeah, it's a great question. So I think the thing that we do that is uniquely is we've set up a framework where you can invert the statistics of contact tracing. So one of the things that you'll often hear is that in order for digital contact tracing to have an impact, you need 60 to 70% of the population using it. So, and that's like a macro top-down approach to contact tracing. And it is true. If you're looking from a population perspective, like an urban population perspective, or from a state perspective, you need 60 to 70% prevalence to for the contact tracing to work at that macro level. But we've inverted that. We've created a model where contact tracing can work for you at an individual and group level. Because the point is right, you need 60 to 70% prevalence of a digital contact tracing solution in the network for the contact tracing to have value for that network. But the question is how you define the network. So what we have done is basically created a network that is centered around the individual. So Jeff gets up in the morning, he's going to go to work, and basically everyone in Jeff's house are the first people that Jeff wants to know that they're COVID clear, they're COVID free. And then if Jeff's going to work, let's say Jeff gets on public transport to go to work, right? Then everyone on that public transport, Jeff would want to know that they're clear. But if Jeff is driving to work, right, and maybe he's carpooling, maybe you're carpooling on the way to work and there's two other people that come with you. You want those two people using the same app that you're using, right? And then when you get to work, you want the majority of people at work to be using the same app that you're using. If you have 60 to 70% prevalence within that corridor of people, then contact tracing works for you, right? It may not work for the whole town. You may have like 0.0001% penetration in terms of the town, but you've got 90% or 60% penetration around your network, within the network that matters to you. So that's the first thing. We've created a framework where contact tracing can work at a micro level for the individual and their bubbles that they're in, those bubbles of people, those pods that they're in. And the second thing is that we've integrated that contact tracing into a complete holistic system. And that holistic system is important for three reasons. One reason is that at an individual level is personalized and individualized to me. So the way that our protocol works is that if you're COVID clear, you're green. If you're at risk, you're amber. If you're infected, you're red. And that's the same for everyone. But the process to go from at risk, amber, to clear, back to green, or to red, well, red is always the same. You only become red if you take a PCR test and you're positive. So that's the only way you become infected. But the real criticality is between being at risk and going back to clear. And if you have preconditions, if you are on medication, for example, then you only go back clear either if you take a test and you're negative, or your doctor gives you consent, a doctor's note to take you back to clear. So you're basically, if you're higher risk, there's a different protocol for going back to clear than if you're low risk. If you're low risk, and let's say you have a cough today for 2 days, well, on the third day, if the cough goes away, you can basically self-clear yourself and you go back to being clear. So you've got this very personalized and individualized set of recommendations on what you need to do, but a very standardized and generic front end in terms of red, amber, green on the credential that's connected to the contact tracing. So that's the first thing we do. The second reason why that's important is because what we're doing with COVID is that we're developing a robust means of curbing the pandemic that is anchored on behavior. It's anchored on behavior and being able to capture behavior, almost like a photograph, right? It's being able to capture behavior and present your behavior as a credential, as something that is reliable in a reliable format. And I think this is really important because, like AIDS, the way that we as a species and as a society have conquered AIDS or defeated AIDS is primarily down to behavior. Yes, we've got therapeutics that are much more effective now, but we don't have a vaccine. We've never had a vaccine for AIDS. But really, the thing that has stemmed AIDS is our behavior, the use of prophylactics, and practicing safe sex as a society. This has been our primary defense in the battle against the AIDS pandemic. Behavior is really our most reliable weapon. Of course, we need vaccines, and of course, we need therapeutics, and we will continue the research for those. But ultimately, our strongest suit is behavior. So that's an important thing from a contact tracing perspective, to have a framework that captures behavior, that allows us to act on behavior, and allows us to use our behavior to give assurances. And then the last thing, which kind of brings the whole thing together, is that very much like masks, this is something that we do not just to protect ourselves, but to protect those around us. So it's a very communal kind of play. It's not just about me as an individual. It's about me as an individual in a community, and about how does my behavior help the community, and how does the community help me.
So in a few months' time, when we're all actually wearing masks in this country and the world, hopefully we'll be able to open up the Health ID app, make sure that we're as connected to that app, feel that it's as important to use that app as it is to wear a mask when we go out of the house. That will help us to fight this pandemic. And that is freaking awesome, man.
Digital PPE, that's what we call it.
Digital PPE. I can't thank you enough for taking the time to run us through your history, your incredible passion on what most people find boring, data, and how it's so life-saving in this time. So I feel really honored to have met you at the health conference, and to be taking these next steps and getting to know you a bit better, Dele. As we progress as a society, we'll need to make sure that everyone is in the loop, everyone gets access to the care and the technology and the communication that they need. So I just want to say thank you. Is there anything you'd like to say to conclude?
Thank you. I mean, thank you very much for inviting me on and giving us a chance to, explain how this works and why it's important. I really do believe that behavior is our strongest defense against this pandemic now. And I just encourage, whether it's our app or apps like it, I think people should be really using these digital tools to try and get ahead of this pandemic. Like, I love what you said at the top end. They didn't have that in 1919 and 1920. We're not in the 20th century anymore. And there is no reason why we should have something like 50 million deaths. We still don't know how many people died from the Spanish flu, the so-called Spanish flu, right? But it's in the region of 50 million deaths. And there is no reason why, as a species, we should accept that kind of death toll. We shouldn't be accepting hundreds of thousands of deaths in America. There's no reason why there should be. We can't change what's happened. 220, almost 230 plus thousand deaths today, but we can prevent there from being tens and hundreds of thousands of deaths going forward. So I would just hope that people can take the mask up and app up.
App up. Excellent. Love it. All right. So thank you so much, Dele. It's been a pleasure.
All right. Thanks, Jeff.